So to recap our previous lesson, we were talking about hormone cascades and how, especially in the hypothalamic pituitary and then some sort of target organ axis, there's a hormone cascade, and with each wave of hormones, you release more and more hormones. So that's how you amplify a signal. But how do you turn the signal off? And again, this is the pituitary gland. It doesn't control all the hormones in your body, but it does control a lot of the hormones, right? So with the hormone cascades, what we saw is that with each consecutive wave of activation along hypothalamic pituitary hormonal axes, we saw this increased signal called amplification. Now, how do you turn this off? This is where we have to talk about feedback. So it's not just about turning hormones on, but it's also about turning them off if there's too much of that, that's beyond what you really need, or say your body no longer needs the changes caused by a hormone. How do you turn that off? So when I use this kind of shorthand, sometimes people use arrows as a common way of saying that something's activating or some sort of positive effect on something. And this double blunt arrows right here is a common notation used for inhibition. Sometimes you might see a diamond, sometimes you might see a dot. Arrows that are pointed are usually saying that, okay, we stimulate something, and we did talk about stimulation. These are our cascades we talked about. But now let's talk about the inhibition part and why it's important. So with hormonal levels and going all the way back to the first chapter and talking about homeostasis and balancing and maintaining normal levels in your body. So whenever there's like a feedback in terms of hormone, it's when a hormone somehow affects its own production. So all hormones, they have to, you want a normal level of hormones, and maybe if you need the additional boost of that effect from that hormone, you might make more of that in the body, or say there's too little. You want something to bring it back to that ideal range. Now there are two general types in terms of like feedback with hormonal feedback. We have positive feedback and negative feedback. Now positive feedback I'm going to put off for a few slides and talk about negative feedback, because positive feedback occurs in a few specific instances in your body, and compared to negative feedback mechanisms and hormones that are regulated by negative feedback, positive feedback is relatively rare. So what negative feedback is that it's not just about keeping things at a certain level and just like, okay, you're always going to have this exact concentration of hormones. Well, the thing about negative feedback, like you have your body, sometimes you can feel hot, sometimes you can feel cold. Your body can tolerate a certain range of things, right? Well, same with hormones. Your body hormones are fluctuating throughout the day, but negative feedback allows these changes, but it tries to restore it back to normal, this normal range that's natural for you. Now, negative feedback, here's a general example of negative feedback. So hormone A leading to production of hormone B, but instead of hormone B triggering the production of hormone A, it's going to inhibit or shut off production of hormone A. So what happens in this situation? Well, say you start having like too much of hormone A. Well, what happens is so I'd like to use this example. So with this negative feedback, you notice that A triggers B, but B turns A off. So the thing is that if A starts to accumulate and the signal from A starts to become very strong, you're going to have increased production of B, and then as B's signal becomes very strong, it's going to slam the brakes on A. So even though so I'll get to this in a little bit, but what happens is that if A gets kind of out of control, it starts to apply the brakes on itself through B. And I love using this little like analogy over here, this little box, and if I had time I would try to make one of these, but electronics are kind of expensive. But yeah, it's so cool. What's happening is that this little switch is being flipped. When that switch is flipped, that activates all the machinery and gears inside, and then this little arm comes out and it shuts itself off. So this little box likes to stay undisturbed and it likes its switch to be off. That's its homeostasis. But you can disturb it. You can offset it by flipping that switch. That causes things inside the box to change, and those changes end up turning the box back off. So, but we are seeing dynamism. We are seeing some changes in this box's state. So that's the cool thing about negative feedback. It's able to kind of turn itself off and restore it back to its original state. So what's happening again, you have a change in the system, and then changes in the system set off this cascade of other reactions and other things that happen that ends up turning itself off. So this is like what negative feedback is. Or when we talked about homeostasis, like in temperature regulation, like if we get too hot, what do? We sweat. The sweat helps us cool off. That brings our body temperature back down. On the opposite, say we're very cold, what do? We shiver. All the movement and extra heat generated by our skeletal muscles contracting, that heats us back up, so we're no longer cold. And okay, so negative feedback controls hormone levels. So like say we have hormone A in this previous example accumulating, that's going to increase the signal from hormone A, and that's going to trigger the production of hormone B. Now hormone B is going to, because there's a lot of hormone B now, it's going to apply the brakes harder and inhibit the production of A even more. So if you're inhibiting the production of A, what eventually happens in your body is that A is going to drop off. And as your body, your body is always kind of turning over things. So if you're stopping the production of A and A is being cleared from the body, then that's going to lower the levels. If you lower the levels of this first hormone, you're going to lower its signal, thereby lowering the production of this hormone B in this example. And then that eases up on the brakes, so to speak, and now A can accumulate again. So that's what we have here. So here's a real example. So what's an example of an A and B sort of negative feedback? Well, let's go back to the pituitary gland. We have ACTH being produced by the pituitary gland, and then this is going to target the cells in the adrenal cortex to produce cortisol. And cortisol, now this is the part we didn't get to, is that cortisol actually can act upon the pituitary gland and then shut off production of ACTH. So if ACTH levels drop, what happens to the levels of cortisol? Cortisol drops as well. So now we don't have as much cortisol anymore, but now we can have restoration of ACTH secretion from the pituitary gland, and the whole cycle can start over again. So we often have these fluctuations because why? Well, we have the production of a hormone, but it's ending up shutting off its own production. So this is what's happening with cortisol's negative feedback on ACTH. You need ACTH to produce cortisol, but if your cortisol is shutting itself ACTH off, it's going to inhibit its own production. So this is a good way of preventing cortisol, because remember in the previous cascade, we saw that we have more and more hormone produced, but if you produce too much of this hormone, your body has a way through negative feedback of dialing back excess levels of hormones. Okay, now the HPA axis. Now the interesting thing is okay, what about CRH? You might be like, okay, wasn't there hypothalamic control? Yes, there is. There's that CRH that triggers the production of ACTH, and then that targets the adrenal cortex to produce cortisol. Now, cortisol, as we established, affects the pituitary gland, but it also targets the hypothalamus. And what it does is actually another negative feedback over here. So yeah, we have here with the negative feedback over here is a hypothalamus pituitary. So this is very interesting. In a lot of the hypothalamic pituitary axes, the final hormone that's being released, the one with the effects from that's being secreted by that endocrine organ, often applies the brakes not just on the pituitary gland, but also on the hypothalamus. So if you have that, what happens is that this whole cascade is being shut off by its final product. So if you have excess levels of cortisol, meaning that you have way above high levels of cortisol than normal, it's going to shut off its own production, thereby allowing the body to kind of clear the excess cortisol and bring it back to normal. But if there's a lack of cortisol, you're not going to have the brakes, so your body's free to accumulate the cortisol again. So this is pretty typical of the hypothalamic pituitary, the HPA axis, and the HPT, the thyroid axis. They both function like this, and also on the HPG axis as well. So this negative feedback is kind of baked in there because you don't want high levels of these hormones or excessive levels of these hormones. Now, let's talk about positive feedback. We might get another additional chance to talk about this at the end of the semester. But what is positive feedback, and why don't I emphasize, or it's not that it's not important, but in terms of homeostasis, it's negative feedback is more important because it maintains a normal range. Positive feedback accomplishes specific purposes, and this is why it's relatively rare. So if we were talking about positive feedback in the endocrine system, instead of a hormone triggering its own alert, shutting its own production off, you have a hormone stimulating something that triggers the release of more of that hormone. So we see this in the menstrual cycle at certain points, but that's very complicated. I'm going to save it and table it for when we talk about the menstrual cycle at the end of the semester. But and again, instead of negative feedback, positive feedback is just going to be A causes B, but B increases A. So we have this like stimulation. It's kind of like a little echo chamber. Like A causes B and B causes A, and then if they accumulate, you notice that the signal of both gets stronger. So this is what positive feedback is. Instead of B turning off A, now you have B stimulating the production of even more A, which triggers the production of even more B, and so on and so on. And then, how do you shut this off? Does this keep spiraling out of control? Well, usually it ends with a major event, and what is that event depends on what you're talking about. Now, an example of this is the Ferguson reflex. So over here, she's up high, and this is her uterus, and she has a baby in there. Now, say the baby is exerting pressure on the cervix, and the interesting thing is that when you exert this pressure on the cervix, and if you don't know what the cervix is, don't worry, we're going to talk about female anatomy later on in the semester. But this sends signals up to the brain, and more specifically the posterior pituitary gland. And the posterior pituitary gland is going to produce oxytocin. And oxytocin, remember, our love hormone, our trust hormone. Well, this is another function of oxytocin. So oxytocin is going to target the uterus, and when it targets the uterus, it's going to increase contractions, and not just increase the rate of contractions, but also the strength of contractions. But remember, we already have that baby in there. So if you have something solid in there, and so that might be around 10 pounds, and you're squeezing the surrounding area, what is that going to do to the pressure on the cervix? Well, that's going to increase the pressure on the cervix, and then if you have more cervical pressure, that's going to send stronger signals up to the posterior pituitary, and that's going to trigger the release of even more oxytocin. More oxytocin triggers faster and stronger contractions. More contractions with more pressure stimulates that cervix even more. So this is why these contractions during labor start to increase in amplitude and frequency. It's all due to a positive feedback loop, or I should say primarily caused by a positive feedback loop with oxytocin. So what we see is that oxytocin is starting to build up and build up and build up. What's the major event that breaks this cycle? And when you release the pressure. Well, not with that velocity, but if you don't have the baby in there anymore and you deliver it, then you don't have any more pressure on the cervix. So you don't have this strong signal going to posterior pituitary, and therefore the oxytocin can drop off again. And is this cycle going to continue again? No, because the baby's already delivered. Okay. So a little anatomy, and also a little review of anatomical directions. So the adrenal glands. So I talked about the adrenal glands, but where are they? Okay, let's see the responses. And most of you said they're superior to the kidneys, and that is correct. And I did do a little spoiler earlier, and this is where it is. So again, our kidneys are in our abdomen, and more specific, retroperitoneal, but we'll learn more about that later on in the semester. But again, just like you have two kidneys, you have two adrenal glands, and these adrenal glands sit right on top of the kidneys. So they're not fat, even though they look lumpy and yellow. They are important glands, and they're not they're attached to the kidneys, but they're not the kidneys itself. Okay, so the adrenal gland, again, with our anatomy and superficial and deep, so superficial meaning outer, deep meaning inner. And there are different layers to the adrenal glands. So we're looking at a cross-section here. So we have the capsule, which is dense connective tissue that surrounds this gland. But we have our cortex that's relatively towards the outer, or compared to the medulla, which is the innermost part of the adrenal gland. The cortex is between the capsule and medulla. So again, if there's a cortex and a medulla in the same organ or tissue, the cortex is typically superficial. The medulla is relatively deep. And then, so what hormones are produced by the adrenal gland? Let's talk about more. And you might be like, ooh, okay, think about, what hormones are produced? Well, thing is that you already know three of them. And what you might be, whoa, three already? Yes, you did cover this. And a little review from last semester and the sympathetic nervous system. So with a typical sympathetic activation, what do you have? You have a preganglionic nerve fiber, then you have a ganglion, which again in the peripheral nervous system is a collection of cell bodies. And then we have the postganglionic neurons, sometimes just called ganglionic without the post. I like to say post just to make it a little more specific and clear. But what we have are two main nerve fibers running from the spinal cord, and then an intermediate kind of step here with the ganglion, and then it innervates and activates this target organ. Now, what happens when that target organ is the adrenal medulla? Well, it's a little different than typical sympathetic activation. There's no ganglion, and there's not really a typical postganglionic neuron. In fact, the adrenal medulla itself consists of actually modified postganglionic cells. So instead of a postganglionic neuron, these adrenal medullary cells, they're like the postganglionic neurons. They also secrete epinephrine and norepinephrine, which are important neurotransmitters in the brain and central nervous system. But here, it's actually endocrine cells that secrete it into the bloodstream. So this preganglionic neuron, again, in terms of the adrenal medulla, there's no ganglion. So this preganglionic neuron is actually going to extend all the way into and innervate the adrenal medulla. Because why? Those postganglionic cells are now just modified adrenal medullary cells. So again, preganglionic fibers compared to the rest of the sympathetic nervous system, there's no intermediate ganglion that's bridging a preganglionic and postganglionic. These fibers go straight to the adrenal medulla, no ganglion in between, and this is why, just like how we have norepinephrine is an important neurotransmitter, this stimulates the release of norepinephrine, but now in endocrine context. All right, so sympathetic activation, and remember that this is a link between the nervous system and endocrine system. Here, with the amygdala activating the hypothalamus sending action potentials down the spinal cord, activating sympathetic activity, activating these preganglionic nerve fibers. Well, this is going to innervate the adrenal medulla, and now we have secretion of epinephrine and norepinephrine. So that's like a link. So everything up here is nervous system, but now that we have the release of these chemicals into the bloodstream is now a link between the endocrine system and the nervous system. So these are now hormones. But there's also something else. So the thing about the adrenal gland is that there's multiple layers. We have our capsule, our adrenal cortex, and our adrenal medulla, but the adrenal cortex also has sublayers as well. So this is like a little, and I think this is in your slides as well, and it's a nice little table of summarizing the different layers and the types of hormones they produce at different layers of the adrenal gland. All right, so the adrenal cortex. Now let's go a little more outer. So we're not talking about the capsule, but we're talking about everything between the capsule and between the medulla. So this is kind of like the middle layer of the adrenal gland. And what do we have? Well, we did cover this axis. We did cover the HPA axis. So then remember, to review, again, we have our hypothalamus, and it's releasing CRH. That stimulates the pituitary gland to release ACTH. And then ACTH is going to stimulate the adrenal cortex to produce that third hormone we already know about, cortisol. Now let's talk a little more about cortisol. Well, cortisol is made by the adrenal cortex, but more specifically a particular layer of the adrenal cortex. So there are three main layers to the adrenal cortex. We have the zona glomerulosa, the zona fasciculata, and the zona reticularis. Now, the layer of the adrenal cortex that makes cortisol and other glucocorticoids is that middle layer of the adrenal cortex. So the zona fasciculata, it produces cortisol, and it does produce, or actually in general, it produces a category of hormones called glucocorticoids. And the primary one I want you to know for this class, not that the other two aren't important, but for this class, I definitely want you to know cortisol for sure. Now you might be like, okay, this is cortisol, but what are the other two and how are they different? And I'm showing you the chemical structure, and again, if you haven't had chemistry or organic chemistry, this might look like you don't know what's going on here. They might look all the same to you, but are they all the same? Well, they are slightly different. They look very similar, but there are slight differences in these chemical groups right here. Do I expect you to know that? No, again, this is not organic chemistry class, but I'm showing you that they are very structurally similar, but they are distinct chemical compounds that act very similar, but they're not, again, they're not the same thing as each other, but they are in that same category. So often, especially if you're going to pharmacology or medicine, you might have chemicals that are structurally similar, but they act in similar ways, but they're not exactly the same. There are slight differences, but don't worry about it for this class. Speaking of these structures, now let's do another question. So those were our glucocorticoids. What do you think they're classified as? Collapse. Okay, let's see over here. So they are, most of you said that they're classified as steroids, and most of you are correct. They are classified as steroids because, again, look at that classic 4-ring structure. Count them: 1, 2, 3, 4. Those 3 hexagons linked to a pentagon, so they are steroids. That's why, like in common parlance, and especially people who like talking about things like PEDs, they say steroids, but are all steroids the same? No, cortisol has different things, different properties. Now the thing about this is that, okay, they're all very similar in structure, but they actually also bind the mineralocorticoid receptor. But for this class, I want you to talk about their glucocorticoid properties. So they are different chemical structures and very similar, but again, they have slight differences. But they are able to bind to this glucocorticoid receptor in the cytosol of a cell. So this is why they're all collectively called glucocorticoids. Now, in general, glucocorticoids have very similar properties, and some of these might have more. You might need less of a certain. So glucocorticoids cause the same effect as another. Well, actually, don't worry too much about that. That's a rabbit hole for your biochemistry classes. But glucocorticoids, what do they do in general? So here's cortisol. So they can actually increase your blood glucose and affect your glucose metabolism. And we'll talk about blood glucose more in detail in the upcoming weeks. Also, fat metabolism is just very important in generating those adipocytes, and also fat storage and conversion between glucose and fats and triglycerides. They also have very important anti-inflammatory properties. So things like prednisones or dexamethasone, they have very similar structures, and you can look at up the chemical structures, and they look very similar to cortisol and other glucocorticoids. They act upon the same receptor. Why? Because, and someone mentioned that they had a pinched nerve, and they want to have cortisol and cortisone shots because it helps with that inflammation and pain. So but the thing is that it also suppresses many immune functions, and that's linked to the inflammation. We'll get more to that, more about inflammation and the immune response at the end of the semester. And cortisol is actually the same chemical structure as hydrocortisone. But cortisol, when it's used, that term is used, it's usually referring to what we call endogenous levels in your body. So that means this is the cortisol that your body is making. This comes from your body, whereas hydrocortisone usually refers to pharmaceutical applications. So it's like thinking of like extra cortisol you're adding, but this is instead of being naturally produced by your body, it's some extra cortisol that you're having from like something like this hydrocortisone cream. So yeah, it's the same chemical structure, and sometimes it depends on context. Is it produced by your body, or is it a drug you're adding to your body? That's related to the terms endogenous and exogenous. So endogenous is kind of made by your own body. Exogenous would be something like this hydrocortisone cream, where it's something outside of your body, but you're introducing it to your body. And it's a catabolic steroid. So again, like you ask someone on the street, they probably know what a steroid is. But instead of being an anabolic steroid, it actually promotes the breakdown of a lot of tissues. And why do I make this? And even the term anabolic and catabolic, some endocrinologists and physicians don't like this term, but I think it's kind of useful in talking about general properties. And why do I bring this up? This catabolism is like, do you want to be injecting a bunch of cortisone before the Olympics if you were allowed to? But Here's an example of something called Cushing syndrome, and this is hypercortisolism, meaning that people who have this condition, they have above excessive levels of cortisol in their body. Now, what are the classic symptoms of hypercortisolism? What you have differences in this buffalo hump is mostly adipose tissue and fat, and osteoporosis. We did talk about this a little last semester, and then what's happening is that you have a breakdown of bone tissue and the structure of bone tissue, so it's becoming brittle. Muscle wasting, so it's breaking down muscle. So say there was like a non-drug testing athletic event. Do you want to be putting a whole bunch of cortisol like it's some sort of like anabolic steroid? No, because it's going to waste all your muscles. And then it also affects skin ulcers, poor wound healing. Remember that your skin is always regenerating, so this is something that's breaking down the skin. And this is why you also see these abdominal striae, but these are the stretch marks that appear with people who have Cushing syndrome. And this moon face and this cardiac and obesity, this is due to abnormal fat deposition as well. So there are many things, and it's just showing you how powerful these hormones can be, because there are many target organs of cortisol. Therefore, if you have excessive levels of cortisol, that causes all these big changes throughout the body. So this is why you see this buffalo hump and this moon face. I mean, it's a terrible term, but that's what they describe it. This kind of round, puffy appearance due to all this fat and also forming in places that weren't there before the hypercortisolism. And cortisol, again, is generally catabolic because we see that's breaking down all these tissues, but doesn't break down all tissues. Well, we do see this something called cardiac hypertrophy, so that means the heart is actually enlarging, but maybe we'll get time to talk about that when we talk about the heart more in detail. Yeah, look at this too, another example. So you can see that kind of puffiness and roundness, so I guess that's why they call it moon face. And we also see those stretch marks as well, because not only we have this breakdown of the skin and the dermis and the connective tissues that help to give the skin its structure. Now, there's also something called Addisons disease. So is cortisol necessarily bad for your body? No, the thing is that there's for all the hormones in your body, there's a general normal range. Now, Addisons disease is a named version of hypocortisolism. So now we're talking about having too little of cortisol. So this can be due to congenital defects in the adrenal glands or something. Sometimes you might have adrenal glands, but for some reason they're not producing enough of the hormones they normally produce. So this is why sometimes it's also called insufficiency, meaning that they're not producing enough cortisol. And there are many things that can happen. And here we have hypoglycemia. So again, cortisol, many effects, but also in terms of regulating your blood sugar, which we'll get to in very shortly. And also things like weakness, weight loss, hypotension, meaning that you have low blood pressure, changes in the distribution of body hair, and differences in pigmentation of the skin. But especially this weakness and this low blood pressure, those are things that are pretty debilitating. So how can you help treat that? Well, introduce more cortisol to the body. So yeah, hypoglycemia, low blood sugar, hypotension, low blood pressure, hyperpigmentation, that's what they were referring to with this bronze pigmentation of the skin. And over here, now what we see is that this individual with Addisons disease, they have hyperpigmentation of their gums. So you can see their lips and the inside of their mouth, but yeah, this hyperpigmentation, they have really, really dark gums. Not all of them will have this, but this is a classic giveaway or something that strongly suggests Addisons disease and hypocortisolism. And this back to U.S. history. So this is like John F. Kennedy, and he actually had Addisons disease. And so what happened is that he had a medical team that made sure that he had enough of cortisol in his body so that he wouldn't be suffering from hypoglycemia and hypotension and all the weakness that occurs with that. And yeah, so he had Addisons disease, and there was so he needed daily steroids to survive. Does that mean he was getting super jacked and being pounded with all this andro? No, again, it's a different type of steroid. He has a lack of cortisol, so they were giving him supplemental cortisol to help bring up his blood pressure and regulate his blood sugar. So because without it, he would be otherwise weak. Yeah, so adrenal daily corticosteroids of some form or another. All right, so then that's the adrenal cortex, and we talked about cortisol. Again, there's glucocorticoids, but the main one I want you to know is cortisol. And this is in that middle layer of the adrenal cortex called the zona fasciculata. Now, the primary target, again, this is why with hyper and hypocortisolism, it's not just one organ being affected, it's practically the whole body, and almost every cell in your body expresses or has that glucocorticoid receptor. Now, this is stimulated by ACTH. That's why it's important to know that HPA axis. Now, let's talk about another layer. Let's talk about the layer that's a little more superficial. That's right next to the capsule, the zona glomerulosa. And it produces a category of steroid hormones called mineralocorticoids, primarily, and the main one I want you to know for this class is aldosterone. There are other ones, but aldosterone is the one I want you to know. So it is the primary mineralocorticoid. There are others, but this is the one with the most powerful effects. Now, it's important for maintaining, and minerals, well, think about, when you think minerals, you think like, oh, minerals and vitamins. So these are important in maintaining electrolyte balance, so such as sodium and potassium ions. And it's very important for our blood pressure and volume, and I'm going to actually reserve this and put this off into Unit 2 when we talk more about blood pressure and volume, because aldosterone actually works in conjunction with other hormones, and I will cover those hormones when we talk about blood pressure for Unit 2. Now, but before I want you to know is like aldosterone important in maintaining blood pressure and electrolyte balance. I want you to know the very basics, but we'll cover this more in detail later on. Now, the third main layer of the adrenal cortex, the deepest of the adrenal cortex, is the zona reticularis. And this layer is primarily responsible for producing androgens. So what are androgens? Well, androgens are the primary male sex hormones, and there's actually many, so pretty much everyone has probably heard of testosterone, but all 6 of these, and they're all steroids because they have that classic 4 ring structures, the 3 hexagons and the pentagon, and they all act upon the same receptor, the androgen receptor. Now, the thing about steroids is that this is more of the med school students have to know this. I don't expect you to know this, but this is like what if you're going to medicine or pharmacology or biochemistry, this is what you're getting into. But all these over here, these are androgens, and they can be converted into different steroid hormones. So we have the androgens highlighted in this blue box or boxish shape here, and then they're being converted by an enzyme. And again, if you were here last semester, what 3 letters are a dead giveaway that a protein is probably an enzyme? Let's ask the chat real quick. So if a certain protein ends with 3 certain magical letters, what makes it most likely to be an enzyme? Oh, someone said, yeah, ASE. So that's a giveaway. Not all enzymes have ASE at the end of it. But yeah, that ACE. So there's a special enzyme called aromatase. And what this aromatase is going to do is convert androgens to estrogens. Yeah, so this is important. And aromatase is found in many tissues, and we will get to cover other tissues that express aromatase. But yeah, especially like aromatase helps to convert androgens to estrogens. That's why if someone is saying taking a lot of anabolic steroids and androgen analogs and it's being converted or taking a whole bunch of exogenous testosterone, well, yeah, maybe they'll build up their muscles, but this is why they often get this like secondary sex characteristic, female sex characteristics developing and growth of breast tissue, because if you have a lot of testosterone, aromatase can convert that to estrogens, and estrogens can stimulate the production of mammary gland tissue. So this is why, and especially for androgens, these can be converted to estrogens. That's why people who have a lot of aromatase activity in their body, they might have higher levels of estrogens. But that's something we'll cover in a future lecture. So yeah, what I want you to know is that there's adrenal cortex, but there are sublayers. In terms of their effects, like I don't want you to go to like primary reason. I think was it like yeah, both textbooks can go kind of into super deep detail with the hormonal effects. I think this chart right here is pretty much a good starting point and pretty much what I want you to know for at this point in the semester. I might go in more into detail, especially when we go back to the reproductive system and we talk about blood pressure and regulation of blood volume and fluids in your body. But at this chapter, this is where I want you to start with these hormones and where they are located. Okay, and I'm going to try to cover the thyroid gland. I have a feeling I might run out of time. If not, so this will be really quick. But I'll try to, if I don't get through it enough time, I'll just like table the rest for Wednesday. All right, so we talked about our hypothalamic pituitary control. So we have, remember in our HPA axis, we have corticotropin releasing hormone, ACTH, and then we have cortisol, and also androgens and aldosterone. Well, the thing is that with our HPT axis, very similar, but a different set of hormones. So this set of hormones will be, again, it's like instead of CRH, now we have TRH. TRH, this thyrotropin releasing hormone, is going to stimulate the pituitary gland to produce thyroid stimulating hormone. Thyroid stimulating hormone, or TSH, is going to target the thyroid gland, and that's going to tell the thyroid gland to produce and release thyroid hormones, T3 and T4. So yeah, TRH, TSH, and this is this is where the thyroid gland is. So yeah, the cool thing is like it's right above here, so you can see right, like if you have the thyroid cartilage, and especially if you have a prominent laryngeal prominence, or commonly called the Adam's apple, it's below that thyroid cartilage, and you can actually palpate it, but don't press it too hard because it is pretty delicate. Yeah, you might want to leave it for your physician to do that. You want to like damage your thyroid gland, but it's right over here. So say someone has a physical abnormality with the thyroid, endocrinologist is actually able to kind of like feel like, okay, is there an enlargement or is there abnormal mass in there? So yeah, it's like a little on the lower part of your neck. And this is what you would see on the histological level. So what we have are all these little spaces called thyroid follicles, and these are surrounded by these cells that produce thyroid hormones. So you have all these cells, and if you're new to the semester, all these little purple dots, these are nuclei of each cell. So each nucleus is showing an individual cell, and they contain the substance in the middle of them that's called this is what we call our colloid. And so it's also called colloid, but it's not like, it's called its own special type of colloid, and it has this and it has a mixture of protein, iodine, and developing thyroid hormones. There's also something called C cells. These are not inside the follicle cavities over here. They're actually on the periphery, and these actually produce a different hormone. Now let's talk about the follicle cells. So what happens is that, remember in our previous lectures when we were talking about the different classes of hormones and their chemical structures, that thyroid hormone is unique in that it integrates iodine into its chemical structure. So you need way of actually getting iodine into this thyroid gland. So we have this ion pump that's able to actually bring in iodine and bring it into the follicle. So these follicle cavities are like storage areas or like little vats where your thyroid glands can brew new thyroid hormones. That's another way to think of it. Yeah, these cavities are kind of like little brewing vessels that will eventually make thyroid hormone. Now, thyroglobulin is a protein, and this is why thyroid hormone doesn't quite neatly fit into monoamines, peptides, or steroid hormones. For one, it's not based off of cholesterol, so it's definitely not a steroid. But it also involves a protein at one step. And this thyroglobulin has a lot of tyrosine residues. That means it has a lot of that amino acid tyrosine in the chain of amino acids that make up thyroglobulin. So what happens is that with all these tyrosines, that if you have two tyrosines that are close to each other on that thyroglobulin peptide. Then the thyroid gland can combine these two tyrosines, link them together, and now we have, well, in this case we have something called thyroxine, also known as T4, because there are 4 iodine atoms. There's also something called triiodothyronine. And why is it called that? Well, if you link a tyrosine that only has 1 iodine atom linked to one that has 2 iodine atoms, well, what's 1 plus 2? You get 3. So again, they're structurally similar. They do bind to the same receptor, but they are chemically different because they don't have the same structure. That 1 iodine does actually make a big difference in terms of some subtle parts of their activity. So thyroid hormones, triiodothyronine. So what are the differences? So they both bind to the same receptor, but the thing is that triiodothyronine, T3, is the more active form, meaning that it binds better to the thyroid hormone receptor, and it causes stronger effects than an equal amount of T4. However, it's less stable, meaning that it's broken down by the body, and the body can get rid of T3 at a faster rate than it does T4. Now, T4 is actually more stable, but it doesn't bind to the receptor and activate thyroid hormone activity as strong as T3. So T3 is more powerful in its effects, but T4 lasts longer in the body. So T4 is more of a storage form of thyroid hormone. And the cool thing is that your body has enzymes that can convert, your cells have enzymes that can convert T4 from its storage form to its more active form, T3. But that's a little advanced, and that's a very, but if you're going to medicine, you definitely gotta know this. And this is more abundant in the bloodstream because it's more stable. So it is an ideal storage form, and then your cells can convert it to T3 if they need it. Now, there are 2 forms of T3, and this is more if you're going to advanced classes, because again, if you haven't had organic chemistry, this is probably all like gobbledygook to you. But there's something else called reverse T3. It also has 3 iodine atoms, but it's in a different configuration. So it's not in exactly the same site. The same iodine is not missing in both of these molecules. But that's more FYI. I don't expect you all to know that, but you should definitely know T3 and T4. Reverse T3, if you're planning on medicine, you should know that. Okay, so then this T4 and T3, so this thing is that this is where all these tyrosines are linked up. And this is why you kind of need these like brewing vats of thyroid hormone in the follicle cavities. So what happens is that they're all linked to that, they're still attached to the thyroglobulin, but now we have those lysosomes, and again, lysosomes often nicknamed the garbage disposals of the cell. Well, in this case, it's not just getting rid of the thyroglobulin, but it's also kind of like detaching a bunch of these, because right now you have all this thyroid hormones stuck to the same peptide chain. So now it can break it apart, so now we have the T3 and T4 that's free from its peptide backbone. So now this thyroid hormones can diffuse out of the cells and into the bloodstream, and then bind to receptors in other cells. What happens next? Okay, is thyroid hormone hydrophobic or hydrophilic? Alright, so is it hydrophobic or hydrophilic? So it's actually hydrophobic, on the hydrophobic side. And why is that important? Well, again, remember that with the things that are transported across the plasma membrane, things that are very hydrophilic have a hard time crossing the plasma membrane. But thyroid hormone can actually cross the plasma membrane. And the other thing is that it's also this is where thyroid hormone is, again, its own kind of special class, because it actually does have an additional protein transporter in the membrane that helps to transport it. But it is on the hydrophobic side. So this is why I say, okay, even though some other textbooks like Martini classify thyroid hormone as an amine hormone, it doesn't act like a typical amine hormone like norepinephrine or epinephrine or serotonin. So thyroid hormone itself is hydrophobic. So it is able to cross the plasma membrane freely, even though it does have the assistance of a transporter. But by being able to cross the thyroid hormone or plasma membrane, thyroid hormone can also enter the nucleus as well. and it has its receptors in the nucleus, and this is where it can cause the change. And remember that the nucleus is the warehouse of all the DNA in your cell. So when you have thyroid hormone entering the cell and binding to its receptor in the nucleus, that's going to activate genes on DNA that cause the expression of all these mRNA and proteins, and this is where we get our cell response. How does it react? Well, depends on the cell, and again, that's more for a molecular biology class. So the thing is that it acts like the steroid hormones, but it's not made from a steroid. So thyroid hormone transport is more like a steroid hormone, and it activates genes on DNA like steroid hormones, but it's not made from steroids. So again, this is why thyroid hormones is kind of its own special category, and I don't quite agree with just saying it's a lipid derivative or it's a amine hormone. Now, so this is again going to the nucleus. But here's another thing. There are also other receptors for thyroid hormone on the mitochondria. And this is the mitochondria, but more specifically about the mitochondria, fill in the blank. And let's just ask the chat. Blank is the powerhouse of the cell. Yes, everybody knows this, right? So everyone knows mitochondria is the powerhouse of the cell, right? We've seen all the memes, we heard it through high school, but now it's like, okay, what is mitochondria? Why is it the powerhouse of the cell? Well, why is mitochondria the powerhouse of the cell? And yeah. So the thing is that mitochondria are very important in producing ATP. ATP is that very important molecule that can store energy and be used in chemical and enzymatic reactions that require energy. So anything that requires energy, ATP is an easy form of storing energy and your cells using it later. Now, if you had a really good teacher, they might have also told you that, yeah, mitochondria can convert nutrients into ATP, but mitochondria also generate a lot of heat. And why is that important? Well, thyroid hormone affects almost every cell in your body because almost every cell, with very few exceptions, and we'll get to that later in the semester, pretty much every cell in your body has mitochondria. So, and then almost every cell in your body also has receptors for thyroid hormone. So thyroid hormone is a very powerful hormone because it affects almost every cell. And especially like any cell that has mitochondria is going to have an effect. Now, thyroid hormone is very important for metabolism and cell function because of that ATP that can store energy and drive chemical reactions that need energy. So ATP production and also generating heat as well. Yeah, so we already talked about red blood cells. So yes, red blood cells don't have mitochondria, so they're not going to have that mitochondrial effects. Now there's something called Graves' disease, and again, this thyroid hormone, well, you don't even need an endocrinologist to know like, okay, something is definitely different here. So this is what we call a goiter, and this is when this individual right here, it looks like she has a swelling in her right lobe of her thyroid hormone. So yeah, we have this goiter, this enlarged thyroid. But you also get sweating. And why do we have sweating with Graves' disease? What we get in Graves' disease, you have overproduction of thyroid hormone. If you have too much thyroid hormone in the body, that's going to slam your mitochondria with all this activity and activation. Remember, the mitochondria not only produce ATP, but they also produce heat. If you produce too much heat, what's going to happen to your body? You're going to sweat. So also you have tachycardia. So the mitochondria, there's also thyroid hormones. They will also stimulate your heart to beat faster. Tachycardia, especially if you're going to nursing or medicine, you gotta know this term. Weight loss. So the mitochondria are very important for converting the nutrients you eat to energy. So if your mitochondria are in overdrive, they're going to be burning up your nutrients and using up your energy stores. So this is why weight loss is a common symptom seen in acute Graves' disease. Thinning hair, because again, if you're burning through all your nutrients, can these nutrients end up feeding your hair follicles and building up your hair? So thinning hair is also a common symptom. And proptosis, this is also a classic sign of Graves' disease. This is even before my time, but it also causes there's a little pad of fat behind your eyes. So if that fat gets stimulated to grow and increase in volume, then that's going to push the eyes forward as well. So this bulging eyes is also a classic symptom of Graves' disease. And yeah, this is like, oh, Wendy Williams, and it was like 2018. This is terrible. They said crazy eyes, but I'm like, I'm just looking at and look how puffy, and she probably has that same proptosis. And then she did reveal later on that she has Graves' disease, and I'm like, whoa, okay, yeah. So this is like, it's not crazy eyes, it's Graves' disease, and okay, that's confirmation. Like, is that is like, okay, definitely showing in this poor paparazzi picture, in this terrible paparazzi picture and headline, but this is like a classic symptom we see. Yeah, Graves' disease, and she posted a tweet later on. Yeah, so common cause of hyperthyroidism and overproduction of thyroid hormone. And it's often it's an autoimmune disorder. And when we talk about the immune system and antibodies, we can talk about how this happens as a result of your immune system being targeting the wrong things in your body. And it's more common in women. And if we have time to talk about like why, actually we usually don't have time. It's a very advanced question we usually don't have time to cover, but it's an important thing. But that's what, there is a sex difference between the frequency of Graves' disease. Now we have thyrotropin releasing hormone, thyroid stimulating hormone, and this is why thyroid hormone is very important. And it also has a negative feedback loop as well. So you do have thyroid hormone shutting its own production off of TRH in the produced by the hypothalamus, and thyroid hormone also tells the pituitary to stop producing TSH. So in an ideal situation, like if you have too much thyroid hormone, it should shut off its own production. But in Graves' disease, what happens is often with this autoimmune disorder, so auto means self and immune meaning immune, right? So it's some sort of immune reaction, but now instead of targeting something that's like a pathogen, like a bacteria or a virus that's invading, it's starting to target your own body. So what happens in the people with Graves' disease that have this autoimmune disorder is that they have antibodies, but they're going to be targeting the TSH receptors. But instead of like destroying the TSH receptors, it does something interesting where it actually activates it. So it's kind of like, say, like wedging a brick on the gas pedal of these the thyroid gland. So it's going to, by this antibodies binding to these receptors and stimulating to the production of thyroid hormone. This is why people who suffer from Graves' disease, they just crank out the thyroid hormone, and they're trying to do their body's trying to do the negative feedback. But with these antibodies stuck here on the TSH receptors, they're just going to keep on cranking out this thyroid hormone. So this is why it's very important for your immune system to recognize the right targets and not attack your own body. All right. I know I went over the time, but we'll go over it. But yeah, maybe I'll save hypothyroidism for the next lecture. But thank you for staying over time, those of you who could. But just showing you, thyroid hormone is very important because, again, it can affect practically every cell in your body. And this is why we see all those systemic effects when we have a too much. And next lecture we'll cover what happens when you have too low levels of, not enough levels of thyroid hormone.